Hello, this is Mrs. Hahn, and I am going to go over with you Newborn Boot Camp, the story of a baby, which is in your Ricci 5th edition book, chapter 17 and 18. So let the fun begin. Incoming on all this information about babies. So, neonatal transition, that is transitioning after the moment of birth. And when a baby's born, the transition from intra to extrauterine life is dramatic and critical. The first hour after birth is coined the term golden hour of life for that very reason. As newborn transitions to the extrauterine life, their little bodies strive to attain homeostasis with rapid, dramatic transitions in circulation, respiration, thermoregulation, and their ability to stabilize their blood glucose levels. Much of this transition happens in the first 6 to 10 hours after birth, with many adaptations taking weeks to reach full maturity. Over the next few slides, we will go over those adaptations and responses together. So the neonate is the time from birth through the first 28 days of life. Now on day 29, our neonate turns into an infant. The baby goes through lots of different physiological and behavioral adaptations, and in doing so, the baby also exhibits different newborn behavioral responses. So as our neonate transitions to extrauterine life, we have to remember that at the moment of birth, there is a very radical shift in perfusion and oxygenation and their little body systems. During that time, right after birth, we will use the APGAR scoring tool as a quick way to determine if our neonate is doing okay or not. We will also be doing vital signs and measurements, checking the baby's reflexes, doing a full head to toe assessment and potentially a gestational age assessment. And should the newborn need an extra hand during that transitional phase or any time after, we have to do neonatal resuscitation, which is where the NRP or neonatal resuscitation program overview comes into play. So again, the neonatal period begins at the moment of birth through the first 28 days of life, and our respiratory system of the newborn has to adapt from being in a fluid-filled environment, from being inside the birthing parent, to being on the outside world, which is full of air. So gas exchange has to move from the placenta to the lungs. The circulation of our neonate or newborn has to change from fetal to newborn circulation. The hematologic system has to go through some transitions too. So we look at the blood volume of the baby, and that truly does depend on the amount transferred to that newborn at birth. One thing I want to highlight is the fact that delayed cord clamping does help to provide benefits regarding hemoglobin levels, prevention of iron deficiency anemia at between 3 to 6 months of age, and improved myelin brain volume by 12 months of age, as well as improving neurodevelopmental outcomes by 4 years of age. The baby has to learn, its little body has to do thermal regulation now that it's on the outside world. It's not tucked in a warm little environment that is taken care of by the mother and the amniotic fluid. So now the baby has a need for a neutral thermal environment, and hepatic circulation has to occur. So the ductus venosus will close, allowing for hepatic filtering to begin. As far as the gastrointestinal tract is concerned, this little tidbit of information is more of a nice to know or a neat to know piece of information. But the proximity of the birth canal to the anus of the parent helps to actually begin the process of um, transmitting microbes to the baby's system and to their gut. Also, stool changes from meconium to a milk stool. Their renal system, they have limited ability to concentrate urine, and the reduced glomerular filtration rate make neonates susceptible to dehydration and fluid overload when faced with any unexpected imbalances of water, electrolytes, or other disruptions of acid-base balance. And we do want to see our newborns to void at least once within 24 hours of birth. And most term newborns actually do that. Immune system wise, their immune system begins working early in gestation but doesn't function adequately during the neonatal period. It's still immature in a sense. They are protected from certain infections due to the circulating maternal antibodies until they're about 6 months old, but that's not a guarantee that they won't get sick. So we also have to look at natural and acquired immunity for our newborns now that they're outside on the earth side versus being in utero. The major antibody that passes through the placenta to the fetus in utero is IgG. And breast milk is a major source of IgA, which is also considered passive immunity when a baby takes in breast milk and gets the IgA antibodies that way. Integumentary wise, with that system, we know that the skin is a protective barrier and it's a very large organ. The neonates have very sensitive, fragile skin with a neutral surface pH, a lower lipid content. It tends to be thinner and higher in water, which makes our little babies vulnerable to injury and infection, especially when they are preterm. Neurologically speaking, their nervous system is immature until they reach about 1 year of age. And babies will develop in a cephalocaudal and proximal distal pattern. And we will talk about that a little bit later, what that means. And then, of course, we have to be aware of the congenital reflexes or primitive newborn involuntary reflexes that our neonate exhibits and how we check those to ensure that neurologically their neurosystem is intact. Remember that fetal lungs are expanded with an ultrafiltrate of the amniotic fluid, and a fetus practices breathing motions while in utero. So while they're not technically actually breathing air, they practice the motions so that they're ready to actually do those motions on the outside. As the baby passes through the birth canal, ideally, it should get a good squeeze of its thorax, which amazingly can help eliminate approximately 2/3 of the amniotic fluid in the lungs. So, our baby at the moment of initiation of respirations, our neonate has to adjust from that fluid filled intrauterine environment to a gaseous extrauterine environment. So, at birth, when the cord is cut and the baby is exposed to stimulation from normal labor, hypercapnia, hypoxia, and acidosis can occur. And the combination of cutting the cord along with those and the labor stimulation helps with the initiation of respirations. So with that first cry and breath, the lungs should expand and the alveoli are able to pop open. And this is where that role of surfactant comes into play Surfactant is a surface tension reducing lipoprotein that prevents alveolar collapse. So, with adequate surfactant for a term baby, um, when they take that first breath and cry, the lungs should expand and all the little alveoli should pop open and fill with air. So, what do you think happens if the newborn is born really fast or precipitously, or if they're born by cesarean section? Well, neither of those situations allows for the benefit of the birth canal squeeze. The fluids removed too slowly or incompletely, causing um, a lot of fluid to remain within the lungs, and it can cause what we call transient tachypnea of the newborn, which is a respiratory rate greater than 60, along with other signs and symptoms that point to the fact that the baby's having a little bit of trouble transitioning in that initial newborn period right after birth. So we'll review what transient tachypnea of the newborn means a little bit later. What about if the neonate has a bowel movement in utero or meconium? You know, they're not made to do that, but if they're under a lot of stress, or maybe they are post dates or post term, so around 42 weeks gestation or more, um, they can have a bowel movement while they are in the tummy, in utero. So, how can that impact normal respiratory transitioning at birth? Remember, meconium's very sticky and almost glue-like. So, when they take that first initial breath, they might aspirate some of that meconium stained fluid. And because it's sticky, it won't allow all of the alveoli to pop open like normal. Therefore, we could have signs and symptoms of respiratory distress and illness in our baby. So, we'll talk about what that looks like later as well. So, in your book, chapter 18, as you'll see a little bit later, has your chart or table with your normal newborn vital signs. But right now, we're just going to talk about what the respirations for a neonate tend to look like. The normal respiratory rate for the neonate is 30 to 60 breaths per minute. These babies usually have that irregular, shallow, unlabored breathing. They will have short periods of apnea, also called periodic breathing, and that's where breathing will have brief periods of cessation in breathing that lasts approximately 5 to 10 seconds, and they should have symmetrical chest movements. So, if I were to give you a description in a test question of what a baby's respiratory pattern is like, you should be able to pick out what would be normal for the normal newborn, which is what I just described, and what is abnormal, like grunting or tachypnea of a respiratory rate greater than 60, or even nasal flaring. So you need to understand that descriptor of what their respirations tend to be, not just the value of how many breaths per minute. So, what are the chain of events leading to oxygenation? Well, first off, there's initiation of respiratory movement that will expand the lungs and establish functional residual capacity. There's going to be an increase in pulmonary blood flow and a redistribution of cardiac output. So, this is the chain of events that will lead to oxygenation in the newborn once the baby's born. The cardiovascular system and perfusion changes that occur from fetal development in utero throughout neonatal circulatory pattern changes. And we have to switch from the fetal to newborn circulation at birth because now we're on the outside world and breathing in oxygen ourselves. We're not stuck in as a newborn. Now they're not stuck in utero where it's fluid filled anymore. So, with that change from placental to pulmonary gas exchange, there's some physical forces that will lead to increased release of catecholamines that are critical for changes involved in the transition to extrauterine life for our newborn. There's also some fetal structures that we talked about back in chapter 10 within the cardiovascular system that has to make some changes as well. So I'm specifically talking about the foramen ovale, the ductus arteriosus, the ductus venosus, as well as the umbilical artery and veins within that umbilical cord. Now, the normal heart rate, while we used to teach it to be 110 to 160 for a newborn, just like in utero, your book with this new fifth edition has changed what that looks like. So in chapter 18, you're going to want to make sure you understand the difference between one book to the next. So what your book currently says is that the normal heart rate for the neonate or the newborn is 120 to 140. Now, it can go as low as 70 when sleeping, or as high as greater than 170 when they're active or crying. So I'm just going to interject that you need to understand that yes, 70 sounds low. And yes, in real world nursing, we may not like to see our newborn's heart rate go that low. But according to your book, it's giving you those conditional normals. Okay. So a baseline heart rate of 70 is not normal. But if the baby is asleep, it potentially could go as low as 70, but not below that. We also have to take into consideration the blood volume for that baby, which now we have to look at how much blood comes from the placenta once the baby's born. Because remember, as the placenta pulls away from the uterus, when the placenta delivers, the blood can either go out the dirty Duncan section that has pulled away from the uterus, or it can be whatever's within that placenta at that moment can go back into baby. Okay. So that's why, safety wise, having these lotus births can cause a increase in infection and potential blood loss for our newborns. So while we definitely want to consider the wishes of the parents and how that they want to have their birthing process and have things go, we also want to take into consideration that there are some practices that we just need to educate about and we may need to provide more one-on-one assessment time with that newborn. So neonatal versus fetal circulation. So in your book on pages 528 and 529, figure 17.1, on A, you have your fetal circulation where it shows the open ductus arteriosus, the patent foramen ovale or open foramen ovale, and the patent or open ductus venosus down there where the liver's at. And so when you look at B within figure 17.1, it just looks like normal adult circulation. when it comes to our circulatory system. So you have to understand um, how it changes from being in utero to extrauterine neonatal circulation. And so that's where box 17.1 can kind of gives you a good little recap. You can also look at a good little video on, it's a medical animation of prenatal heart circulation from stlouischildrens.org. And Khan Academy has a couple of videos that I use in Edpuzzle. I have fetal circulation and newborn circulation, both in the Edpuzzle. That's really good for you to review and go over as well. But there's also the khanacademy.org site here, should you want to look at that. But this is something you need to know. So when we clamp the umbilical cord after birth, that completely takes the placenta as a reservoir for blood out of the picture. We have the onset of respirations, which causes a rise in PO2 in the lungs and a decrease in pulmonary vascular resistance, which then in turn increases pulmonary blood flow and pressure within the left atrium. We're also going to see that decrease in the pressure in the right atrium of the heart. And at that time, that's when the foramen ovale will start to close. And it starts to close within minutes after birth, secondary to that decreased pulmonary vascular resistance and increased left heart pressure. Now, in your book, you actually have on page 530, it breaks down how long it can take for each of these shunts to actually completely close off. And with the foramen ovale, it can actually take several weeks to have a permanent anatomic closure. But it should close functionally at birth when that pressure difference occurs. Okay? Now, with an increase in oxygen levels after the first breath, that causes an increase in systemic vascular resistance to occur, which decreases vena cava return with the blood and reduces blood flow to the umbilical vein. At that time, now that we've cut the cord and that blood flow from the vena cava that is reduced, that the umbilical vein and those little arteries, they will start to constrict. And so that causes the umbilical cord to eventually become just a ligament with a functional closing. Okay? With that continued constriction of those vessels. And remember, there's not any nerve endings in the umbilical cord. All right? So it's not hurting the baby when the cord is clamped and cut. Now, closure of the ductus venosus, that becomes a ligament as well, but it causes an increase of pressure in the aorta as it closes off, and that forces the closure of the ductus arteriosus to begin within 10 to 15 hours after birth. So the ductus arteriosus becomes functionally closed within the first few hours after birth, and then the ductus venosus will close within a few days after birth. And we don't need that shunting of blood away from the liver anymore because we need the liver to do its job. The placenta is no longer filtering for a fetus. The baby has to do all of that itself. So that ductus venosus is going to become a ligament. Let's talk a little bit about thermoregulation. This topic is absolutely important. You need to understand what it is, what it means, and how a baby can gain or lose heat. And if they lose too much heat, what does that mean? So, thermoregulation is the process of maintaining the balance between heat loss and heat production in order to maintain the body's core internal temperature, and it is very critical for newborns. Newborns are dependent on their environment to help maintain their body temperature, so having a stable body temperature promotes optimal transition to extrauterine life. So, what do we consider as a normal newborn temperature range? Well, your book's going to tell you that 97.7 to 99.5 degrees Fahrenheit axillary is what is normal. Now, I want you to remember, newborns have a big body surface area to have to keep warm, despite the fact that they're such cute little packages. And their heads are the largest part of their body at this stage, outside of just the skin. So they can lose heat very easily, especially after the birth process. And when they lose heat, their bodies try to compensate, but they cannot compensate with the normal shivering like we would do. They actually have to compensate different ways. One is by metabolizing their brown fat stores, and um, so that's called non-shivering thermogenesis. So their brown fat is stored between the scapula, axilla, nape of the neck, mediastinum, and areas surrounding the kidneys and adrenal glands. And that fat is metabolized in order to generate some body heat through warming the blood. So they're trying to warm their blood up that's going through circulation to warm up the rest of their body. That is exactly why it's so easy for them to get cold as a newborn, very easy, and why they can have thermoregulation issues as a newborn. So, how does a neonate lose heat? Well, when an infant or a newborn is exposed to their extrauterine environment, they can lose heat through evaporation, conduction, convection, or radiation. So when they lose too much heat or have excessive heat loss, they can get what we call cold stress. And cold stress requires them to use their compensatory mechanisms like non-shivering thermogenesis and tachypnea, or increasing the respiratory rate to maintain the core body temperature, which can cause a huge spiral and cause their blood sugar to drop and also show signs of respiratory distress. So if you see signs of respiratory distress, we might need to also check their temperature and their blood sugar. It's just a nasty cycle. So here are the mechanisms of heat exchange from page 534. And so you need to understand these, because I am pretty sure at some point between now and when you take your NCLEX after graduation, that you're going to see this or hear this again. So conduction is a transfer of heat from object to object with direct contact with one another. So it requires direct contact. That is where you lay the baby on the cold surface, so their body heat is transferred to the cold surface. Convection is the flow of heat from the body surface to a cooler surrounding air, or air circulating over a body surface. So if we leave a baby with no blanket, no hat on, just down to its diaper near an open door or right underneath an air duct or anything like that, then they're going to lose their body heat to the cooler surrounding air. Evaporation is loss of heat when a liquid is converted to a vapor. That is why we dry our babies off at birth, okay? Because we don't want them evaporating their heat away into the air. And radiation is the loss of body heat to a cooler solid surface in close proximity, but not in direct contact. So students oftentimes get radiation and conduction confused. One is direct contact, which is conduction. The other is indirect contact, which is radiation. So the challenges to thermal regulation, they're thin skin, blood vessels are close to the surface. They lack shivering ability and have limited stores of metabolic substrates, which is like their glucose and glycogen and fat. They have limited use of voluntary muscle activity, large body surface area relative to their body weight, lack of subcutaneous fat, and little ability to conserve their heat by changing posture. They have no ability to adjust their own clothing or blankets to help achieve warmth, and they can't communicate to you that they're too cold or that they're too warm. So, here's your definition of thermal regulation, the balance between heat loss and heat production. How is heat produced? Primarily through non-shivering thermogenesis, or the breakdown of their fat and increasing their rate of breathing to help maintain their core body temperature. And they can lose heat via four mechanisms that could lead to cold stress. Babies have a need for a neutral thermal environment, or NTE. When I say neutral thermal environment, I mean an environment in which their body temperature is maintained without an increase in metabolic rate or oxygen use. The neutral thermal environment promotes growth and stability, conserves energy for basic body functions, minimizes heat and water loss. So it's very helpful to maintain a neutral thermal environment for our neonatal population. So with a higher environmental temperature, skin to skin with the parent, if the baby's stable, using pre-warm blankets and hats to reduce the loss of heat through conduction, preheating the radiant warmer for delivery or keeping the isolate warmed and charged to reduce loss from radiation, drying the baby at birth to prevent loss through evaporation, and promoting early breastfeeding or just feeding in general, whether it's breast milk feeding or formula feeding, to help provide fuel for their non-shivering thermogenesis. Another thing I want to point out to you is deferring the bath until the baby has well-established thermal regulation. So until the baby is a little bit older, so anytime after 12 hours of age is great, but at least about after 6 hours of age, because if the baby's stable, we can use a radiant warmer to put the baby under to do the bath. But that's going to help them get at least a couple of feedings in to give them enough fuel for non-shivering thermogenesis and tachypnea to occur should they get cold. So that's why I mentioned, in real life, it's very helpful if they can have a delay in the bath for at least 6 hours, but 12 hours would be better, much more optimal. Now, babies are able to get overheated. You can leave them in a warmer, a radiant warmer, and if they don't have the correct settings and the correct equipment on to have that warmer automatically change the temperature according to the baby's temperature, we can cook our baby, and we don't like overheated babies. Remember, babies have limited insulation and limited sweating ability, and that predisposes the neonates to overheating. So their little face is going to look flushed, they're going to appear restless, they're going to have increase in fluid loss, their respiratory rate's going to increase, and their metabolic rate's going to increase. and they can't sweat it out. So it's with their limited sweating ability, it just gets worse. So you need to be familiar with thermal regulation, okay? Now, other considerations with neonatal transitioning, um, we're going to talk a moment about immunity, natural and acquired. So, natural immunity is the physical barriers, chemical barriers, and resident non pathological organisms. So, natural immunity would include the antibodies that are passed from the birthing parent to the neonate, either in utero through the placenta or through breast milk. Acquired immunity, it develops after the baby is introduced to something. So, development of circulating immunoglobulins, the formation of activated lymphocytes occurs after they're exposed. So, acquired immunity is absent until after the first invasion by a foreign organism or toxin. And just kind of as a reminder, babies are our newborn population, they're primarily dependent on three main immunoglobulins: IgG, IgA, and IgM. Hepatobiliary, um, we have to look at their iron storage. So, carbohydrate metabolism also has to be considered, and bilirubin conjugation. Bilirubin is the yellow-orange bile pigment produced by the breakdown of red blood cells, and that hemolysis of erythrocytes is the principal source of bilirubin in the newborn. And hyperbilirubinemia, or that yellowing of the skin, can be a normal physiologic process, but there can also be a pathologic reason for excessive hyperbilirubinemia. So we have to be aware of that. So, just as a reminder, remember that before birth, the placenta and the mother's liver handles the fetal bilirubin clearance. After birth, the newborn's immature liver, while it's mature enough to be born on the outside world, talking about a normal term baby, it's not mature enough to do a great job at bilirubin metabolism, but it has to take over bilirubin metabolism once the baby's born. So the death of the red blood cells release unconjugated bilirubin or indirect bilirubin, and that circulates within the system. And that is fat soluble. And so it just keeps circulating. It's really hard to get rid of. And while all newborns have some jaundice, extremely high levels of bilirubin are dangerous and can cause permanent brain damage, or what we call bilirubin encephalopathy, or what we used to call kernicterus. So within the baby, there can be overproduction of bilirubin, which could be due to the Rh-ABO blood incompatibility, drugs, birth trauma, polycythemia, delayed cord clamping, breast milk jaundice. There could be decreased conjugation, which is our physiologic jaundice, but it could also include hypothyroidism and breastfeeding. And there's impaired excretion, and that is biliary obstruction, sepsis, hepatitis, chromosomal abnormalities like any of the trisomies or Turner syndrome, drugs, and believe it or not, inadequate output due to inadequate feeding. So, how do we treat jaundice in the newborn? Well, first off, we want to increase the feeding frequency or the amount if it's inadequate. We're going to strictly monitor the eyes and nose for that newborn. And if the bilirubin level is bad enough at a certain age, depending on when it's drawn, then phototherapy may be warranted. If the breastfeeding or the birthing client is breastfeeding or breast milk feeding, The provider may order additional donor breast milk if they're not making enough milk to meet the demands at that time, or formula if they don't have donor breast milk on hand. So the babies could stay an extra anywhere from 2 to 5 days for this. And we're going to talk about hyperbilirubinemia in a later chapter. So that's all I'm going to go into as far as hepatobiliary concerns are. But you can see jaundice on the pictures on the right beside hepatobiliary and neurodevelopment. And you can see that yellow undertone on that baby's face, and you can see the little yellow hand compared to the adult hand. Now, gastrointestinal wise, there is no peristalsis prior to delivery in our fetus. There shouldn't be. Now, we know that can occur if the fetus gets stressed in utero or if they're post dates. So, therefore, they might have peristalsis, which would cause meconium to occur in utero. But in general, we shouldn't have that. So that first inspiration allows air and bacteria into the GI tract. That's going to help aid in the development of a mucosal barrier to prevent the penetration of harmful substances within the GI tract. And I also need to mention that the physiologic capacity of the newborn stomach is considerably less than their anatomic capacity. What that means is we have a stomach about the size of a cherry or a shooter marble, and it cannot hold large amounts of fluid. So if we're breastfeeding, that's why our colostrum is in smaller amounts, but it's very, very rich in nutrients. Formula feeding, we can overfeed the baby. So when we overfeed, the baby's going to spit up what it can't hold. So some babies could be puking their toenails up from overfeeding. Leads me to tell you about the cardiac sphincter and the nervous control. So the cardiac sphincter and nervous control of the stomach are immature, and that leads to regurgitation and uncoordinated peristaltic activity. I am telling you that it is not abnormal for a newborn to spit up some. What we look at is the amount, how often, and how forceful it is, along with the color and the contents. Okay. So we have to look at everything, the whole picture, in order to say, oh, we have a problem. But it's not abnormal to have some spitting up in our newborn infant population because of that immaturity of the cardiac sphincter and nervous control of the stomach. Now, to gain weight, the newborn requires an intake of 108 kilocalories per kilogram per day from birth to 6 months of age. Those kilocalorie requirements are actually can change depending on the size of the baby, but our normal newborns, 108 per kilogram per day. So neurodevelopmentally wise, we talked earlier about cephalocaudal and proximal distal patterns for their development. So cephalocaudal means the direction of growth is from head to feet or head to toe. If you can break the word down, cephalo or head, caudal, buttocks. Okay, that's like a tail, horsetail. Cephalocaudal. Direction of growth and development is head to feet. Proximal distal developmental pattern means the growth starts from the center. Think about your torso spine, the center of the body, and goes outwards towards the tips of your limbs, your arms and legs. Babies are born with acute senses of hearing, smell, and taste. Their hearing is well developed and they should turn their head to sound. As far as taste is concerned, they can distinguish between sweet and sour just within 2 to 3 days of being born. And they also can develop a preference on what they like to taste, whether it's formula or breast milk. Smell, they can tell their own mother's breast milk from that of others, which is very amazing. The amniotic fluid, the smell of it, which is why we don't want to bathe a baby that is going to be breastfeeding too soon. But the smell of the amniotic fluid on their hands and their body, um, their sense of smell is so acute that they look for that smell and they will actually nudge and push themselves up to the breast because the areola will smell like the amniotic fluid to that baby. So it's kind of like a way, not only does the areola change in diameter, size, and the nipple in size and it get darker, to actually have a bigger target so the baby can, with their poor sight, sort of tell where they're going, but they smell for it. Their touch, they're sensitive to pain and they will respond to painful and tactile stimuli. And their vision is the least mature and incomplete, um, as far as development goes at birth. So they can focus on close objects about 8 to 10 inches away with their visual acuity of being that of 20 by 140 or 20 over 140, which is so poor. So basically, I tell clients that from your breast to your face is about as far as the babies can see. You got to hold your baby up there. They should have the ability to fix, follow, and be alert, and that will show that they have an intact central nervous system. Reflexes, so they have primitive reflexes, and some of the reflexes will remain intact while many will, over time, go away. And when they exhibit normal reflexes upon assessment, that indicates that their neurologic development and function is within normal limits. We can't ask a baby, what year is it? Do you know where you're at? Who's your mother? What did you get on your birthday, your day of birth? What's your favorite present? We can't ask those things. So we have to look at other ways of assessing our baby, to know that they're neurologically intact. Newborn stool characteristics. So meconium is the first stool. It's that top right picture. It's a green-black, tarry, very sticky stool that if it's left on their little buttocks any period of time, it's literally stuck like glue. Now, they usually pass their first meconium within the first 12 to 24 hours. And oh my goodness, the meconium just keeps going and going and going. It makes you wonder, like, how in the world could they be that full of meconium? But they are. Now, as the more days the baby stays um, in that meconium stool stage and it doesn't transition to the milk stool, the higher the risk for hyperbilirubinemia. So we want to see that stool, that meconium stool, come out and start changing to milk stool pretty quickly. Otherwise, the newborn is at much higher risk to have a higher jaundice level. So as our baby transitions, the breastfed newborn, that stool will go to a lighter green. It'll be less sticky and more stringy, kind of mucusy consistency almost, but not hardly. And then it's going to turn to a stringy or pasty yellow green, brown green, brown yellow color before it turns that yellow gold color. It's meconium does not usually have an odor at all, but by the time the milk stool comes and transitions to milk stool, breastfed newborns can have a really sour smell to their stool. It'll be looser, stringy to pasty. It's kind of like you see in the bottom left picture. It's kind of like mustard, watered down mustard mixed with a little bit of cottage cheese because it looks like in that diaper almost sesame seeds, but it's not sesame seeds. It's actually broken down milk, so curds of milk in the diaper. Formula fed newborns, they'll kind of go through the same process transitioning from meconium to the transitional stool to the milk stool. But their milk stool will go to like a yellow green or a brown green to um, a yellow brown or a brown. It'll be looser or pasty and eventually become formed, and it usually has a very unpleasant odor. The frequency of stool varies from newborn to newborn. However, what we educate the parents on regarding voiding and stooling is on day one of life, the newborn needs to have at least one good wet diaper and one good stool diaper, meconium stool diaper. On day two of life, that next 24 hours, at least two of each. On day three, at least three of each. Day four, we add to the urines, and at least we need to see at least three or more stools. So we should see at least four or more urine diapers and three or more stool diapers. Day five, five or more urine diapers, three or more stool diapers. And from day six and beyond until they get a little bit older or until they start taking in table foods around 4 to 6 months of age, then they should have six or more good urine diapers and three or more stools every 24 hours. And so that's kind of how we teach our parents to watch that um, transition of stool. We teach them about, the color transition and everything from birth through the first week of life and beyond. Now, the behavioral patterns of the neonate is very important for you to understand, and there is quite a bit of overlap in these. So, the baby's going to go through the first period of reactivity right at birth. Now, this could be up to the first 30 minutes or even up to 2 hours after birth. And during this time, our newborn's going to be alert, moving, they can appear hungry, they can cry. But at any rate, they're doing those things and they're alert. And this is a wonderful opportunity to do skin to skin and initiate breastfeeding. The next behavioral pattern or stage they're going to go through is a period of decreased responsiveness, meaning that they go through decreased activity and potentially a period of sleep. So this can occur between 30 to 120 minutes old. And that's why I said if we bathe the baby during that phase right then after the first hour of birth, then that real big period of sleep phase can be extended on further because they can go through a deep, heavy sleep. And it can make it really hard to try to wake them up to even formula feed. So it can make it very hard to breastfeed. Now they'll go through a second period of reactivity, and this can last anywhere up to 2 to 8 hours. They'll awaken and show an interest in stimuli. Peristalsis has began. Their heart rate, respiratory rate, motor activity, muscle tone, and muscle coordination increases. And it's not uncommon for our neonate to void and stool during this period. So they have, in that second period of reactivity, their little bodies are waking up and understanding that they are not inside their mommy anymore, and they're going to have to work for their feedings. They've got this weird thing attached to their bum. Now they're getting laid in this hard bed that doesn't, it's not inside their mommy. It don't smell like mommy. It don't make sounds like mommy does inside. So it really kind of can throw our little ones for a loop and cause them to have some overstimulation because of what's going on. So that, before I finish and go to chapter 18, I am going to remind you to look at all your boxes and tables and clinical reasoning alerts and take notes, in addition to just a general overview of studying everything. Now, how do we manage the care of the newborn? The baby's born. Now, what do we do? So, chapter 18 goes over the nursing management of the newborn. And So that's going to involve assessment, intervention, education, and support. So here we're going to look at the APGAR scoring tool, the basic equipment for newborn resuscitation, ABCs for newborn resuscitation, drugs for the newborn, their vital signs, if the gestational age assessment needs to be done, what that looks like, the newborn assessment summary table that's really good. It's nicely laid out for you. We're going to take a peek at that. We're going to go over newborn reflexes, and I'm just going to kind of touch on the growth chart and what that sort of means. For the CDC growth chart, that's in your Appendix D. It goes from birth to 24 months. So that's something that's going to be done more like in your pediatrician's office. Right at birth, though, when we get our measurements, we plot that on our own type of growth chart to help tell whether the baby is an appropriate size, if it's too little or if it's too big. So, and that's in another chapter that we'll go over. So, assessment begins at the delivery of the baby, and at 1 minute of birth, and 5 minutes, we are giving a score to the baby. And Dr. Virginia Apgar created this simple scoring tool to help quickly assess our newborn population to see, is the baby doing good and not going to require any interventions, or is the baby going to need some extra monitoring or going to need resuscitation efforts? So that is the APGAR scoring tool. And so A is for appearance, so remember that's color. P is for pulse, that's heart rate. G is for grimace or reflex irritability. A is for activity, which is your muscle tone. And R is for respiratory or respiratory effort. This scoring is done each section you're giving a score on a scale of 0 to 2 so that the total can fall anywhere between 0 and 10 for a total score at 1 minute, 5 minute, and it can be continued every 5 minutes beyond 5 minutes as needed. So a score of 8 or better requires no intervention necessary. A score of 4 to 7 signifies there's moderate difficulty, that the baby is having some moderate difficulty, and we need to monitor closely for transition support, or we might actually have to give a little oxygen or something like that. A score of 0 to 3, significant distress is noted in the newborn, and we need to begin resuscitation efforts. So the video I usually like to show comes from the Wall Street Journal, and it is actually Dr. Virginia Apgar with a nursing student and a newborn baby who's an hour old going over the APGAR scoring system. There's also another pretty good APGAR test video on Baby Center so that you can look at that as well, but you can YouTube these videos. And your book has a good, nice little table that goes through APGAR scoring, and it's table 18.1 on page 551. Now, if we are having to do any kind of resuscitation efforts, then you're going to make sure that before a baby's delivered that you've got all the equipment needed for resuscitation. That's going to include making sure there's a working wall clock that has the correct time. You need your disposable gloves. You need to have your emergency neonatal drugs on hand, including Narcan. You need to have a wall or tank source of 100% oxygen with the flow meter. You need to have a neonatal self-inflating ventilation bag with correctly sized face mask. I know some hospitals prefer flow inflating instead of self-inflating because the green flow inflating bag or the surgery bag mask that some people call it, you can actually do CPAP with that, but you cannot do that with a self-inflated bag. And then you also want to have endotracheal tubes available. Usually we try to keep a 2.5, 3.0, and 3.5 millimeter handy with introducers and our laryngoscope with the straight blade and spare batteries and bulbs. And then, of course, within our cart, we're not only going to have Narcan, but we're also going to have epinephrine and volume expanding fluids and the items to start an IV as needed. We also need to ensure that the pulse oximeter is placed on the baby and that we have one available that's in good working condition and it gets placed on the baby pretty quickly. When we realize that, okay, baby's, 1 minute baby's going to have help. So, ABCs for newborn resuscitation is going to include airway. So we can put the baby's head in that sniffing position with the head tilted back and the chin tilted forward to open the airway, and we can suction the infant's mouth and nose and see if that helps get the process started with the baby breathing. As far as breathing goes, we can use PPV or positive pressure ventilation for apnea, gasping, or a pulse less than 100. We need to remember that when we do our bag mask breathing or our PPV, that we make a good seal around both the mouth and the nose when giving the breaths. And we're going to ventilate at a rate of 1 breath per 30 chest compressions when it's one person neonatal respiratory, but then that changes when it's multiple people. And then look for chest movement with each breath and auscultate for a rising heart rate and for audible breath sounds. As far as circulation, we're going to start compressions if the heart rate is less than 60 after 30 seconds of effective PPV. Give rapid chest compressions at 90 per minute. Maintain a compression ventilation ratio of 3 to 1 at this point, because at this point you're going to have someone in there helping you, hopefully. And compressions should be performed with 2 fingers at the center of the chest, or you can do the thumb technique when you've got more than one person in there. And you're going to compress 1/3 of the anterior posterior diameter of the chest with your thumbs, okay? So that just kind of gives you an overview of what basic equipment you need and what the ABCs we go through with neonatal resuscitation. And another thing I want to mention, just backing it up, when you're looking at potentially a need for resuscitating a baby, you need to ask 3 questions before you move on. Number 1, is this a full-term newborn? Number 2, is the infant's muscle tone good when it's born? And number 3, is the newborn breathing and crying? If you have answered yes to those 3 questions, then you should not have to do advanced resuscitation measures at that moment. And I say at that moment because of the fact that some congenital heart conditions, that as these shunts start to close off, when they close, they're actually needed to function and stay open for certain congenital heart conditions. And if that's the case and they close off, you might have a baby with a good APGAR at 1 minute, but then shortly after that, they go downhill and they go downhill fast. So that's why I say you can't ever guarantee that just because you have a good 1 minute, that your 5-minute APGAR is going to be excellent too. Okay, so these little pictures just show you some color and tone and facial expressions for the babies that helps show you what grimace might look like. And then, of course, there's all kinds of videos out there as well. Now, other things to watch for during this time include transient tachypnea of the newborn or TTN, hypoglycemia, infection, and physiologic jaundice. And that's all I'm going to touch on that. So remember, APGAR scoring is done at 1 in 5 minutes of life. We're going to be getting that either on the birthing parent's chest or in the radiant warmer. Sometimes the provider who's delivered the baby will actually give the 1 minute Apgar, and then you give, or the nursery nurse gives the 5 minute Apgar, or you may find that you do it both yourself. But if you didn't witness it, you can't give it. So that means looking to whoever had that baby within their sight at that moment and relying on them to help with that score. Now, we need to be considering the fact that the baby's measurements need to be done and vital signs. So after a baby's born, we identify the baby by putting their ID bracelets on that matches the mother's. And this can be done while the baby is skin to skin. And then we do vital signs. Everything else, including their footprints, can be done after the baby is done with skin to skin. There are things that can be done while the baby's on, doing skin to skin, and there's things that you can take 10 to 20 minutes with baby, when the parent's done with doing skin to skin, and quickly do what you need to do. So their measurements, that's one of the things you can hold off on and do. And then you need to plot it on the growth chart. Now, when a baby is not doing well, we're not going to do skin to skin. That's going to have to come after the baby's stabilized. Now, we also perform a congenital heart disease screening along with, and that's an oxygen saturation at any time after 24 hours of age. The baby should be getting blood pressures at birth. They may need to be, according to facility policy, repeated before discharge. And of course, we get an oxygen saturation preductally on the right hand or wrist at birth. And then, of course, the congenital heart disease screening we might need to do, depending on the hospital policy. It's based off the postductal screening, which is your left arm or either of your lower limbs, either leg. And some hospitals want the preductal, which is the right arm, and the postductal both. Gestational age assessment, then that's also called New Ballard scoring or Dubowitz score. And we'll go over that in a moment. But I want to go back up to your vital signs. Table 18.2 in your book, it actually is on page 557. It gives you the ranges of those normal value ranges, and we've already went over the temperature being 97.7 to 99.5 degrees Fahrenheit, 120 to 140 beats per minute for the heart rate, but as low as 70 with sleep, as high as 170 plus with activity or crying. The respiratory rate's 30 to 60 breaths per minute at rest, increasing with crying. The blood pressure is 50 to 80 millimeters of mercury systolic and 30 to 55 millimeters of mercury diastolic. And so that's what we go by. Now, back to Dubowitz scoring or gestational age assessment. We're looking at the baby's physical maturity and their neuromuscular maturity, and they get a score for their physical maturity separate from their neuromuscular maturity according to figure 18.18 in your book. We add those physical maturity score and neuromuscular maturity score together, and we compare it to the little chart that's on that gestational age assessment tool to be able to tell us if this baby physically, when we assess it, is falls on a certain gestation according to their assessment, which could differ than their gestation according to the due date or even the ultrasound date. Okay. Here's your newborn vital signs, table 18.2 that I just reviewed. Here's just a quick overview of gestational age classifications and gestational age size. So preterm or premature is prior to the completion of 37 weeks gestation. So we go to, or prior to 37 weeks gestation, not the completion. We go from after 20 weeks all the way to 36 weeks and 6 out of 7 days weeks gestation. So, term gestation, 38 to 42 weeks, post term or post dates after 42 weeks, which is also post mature, especially when there's placental aging involved. Size for gestational age, we can also use that gestational age assessment tool and plotting our measurements to be able to determine the size for gestational age. And we're looking at whether it's small for gestational age or SGA, appropriate for gestational age, AGA, or large for gestational age, LGA. The younger the gestation is for the neonate on that gestational age assessment tool, the further left the assessment's going to be on the scoring tool, and it will reflect that when you actually look at the key to determine the gestational age. It's going to correlate with being preterm. Okay. Interventions that we perform may take place in a labor delivery recovery room, in the OR, in the transition nursery, in the NICU. But we're going to maintain airway patency, ensure that proper identification gets done, administer prescribed medications. Vitamin K is a vitamin, and we give it because the babies are born with that sterile gut, and it's going to take a lot of feeding and time to build up enough vitamin K in their system to help prevent and help with clotting, to help prevent any problems with bleeding. So if a baby doesn't get vitamin K at all, they're usually by the time they're around 8 days old after that first week, they usually have enough built up, but some don't. So it's given prophylactically. It's also, if it's a male baby who's going to get a circumcision, providers, if it's going to be done in the hospital right after birth, usually after 24 hours of age, but before discharge to home, the doctors and nurse practitioners will make sure that the baby receive vitamin K, or they will not do that procedure, that surgery. Eye prophylaxis, we give erythromycin ophthalmic ointment, and it's given prophylactically to prevent infection of the eye. Okay. So if a baby gets infection in the eyes, then depending on what's caused the infection and how bad it gets, like maybe gonorrhea, chlamydia, is their organism, then the eye infection could actually get bad enough to cause damage to the eyes and even blindness. So it is given prophylactically to try to prevent infections of the eye. However, we don't need to say that it prevents blindness, because that is not true. Okay. And we also need to maintain thermal regulation of the newborn. Head to toe exam, page 609 through 624. Newborn assessment summary, table 18.3. And then, of course, this is going to help you if you could understand what's normal and those common skin variations and common variations, especially when it comes to physical, developmental, and behavioral, you're going to be able to pick out what's abnormal. So you're also going to document all of these findings, whether it's charting by exception or having to make actual notes, but you're going to notify your provider as needed. Common skin variations that occur include vernix caseosa, which you can see with A, which is actually salmon patches or stork bites on the nape of the neck. You can see a little bit of white, almost looks like lotion or something cheesy right there in the nape of the neck. You also have stork bites that are not only located on the nape of the neck, they can be located on the eyelids, between the eyes, and other places. They're hyperpigmented areas of the skin that should lessen in color over time. Most of the time, they completely go away. Milia is B. It's these little white, pimply almost looking spots, but it's not pimples. Parents should not be trying to pop them or scratch them off. They just go away on their own. Mongolian spots is C, It looks like that purpley blue shaded area on the buttocks of this baby and on the leg. Um, and sometimes parents will think it's bruising, but it is not, and it can be considered a birthmark because it doesn't always go away. You typically find Mongolian spots on um, babies and populations that have more melanin in their skin. So Indian, Asian, African, Black, Hispanic, Latino. I mean, I could go through and name a whole list of ethnicities for you, but we're going to stop right there. Erythema toxicum is a really scary term. It's D, it's those little red spots and blotches on the baby's face. Erythema toxicum is actually newborn rash, and it occurs because the baby is now exposed to the air on the outside world and it's not in a fluid filled environment anymore. It comes and goes, it's benign. There's nothing we do to treat it, and it's usually resolved by the time the baby's a week old. Nevus flammeus is also called port wine stain. It is E. It is a very dark purplish red staining of the skin. It is a birthmark. It will not go away, and it has very noticeable demarcations of the lines on it, and it's flat. But nevus vasculosus, which is F here, is a strawberry hemangioma. It is actually raised and sort of bumpy, and it actually has usually a pretty nice blood supply that goes to it, so they can actually grow and get worse. Common malformations of the head include caput succedaneum and cephalohematoma or cephalohematoma. Caput or caput succedaneum involves the collection of serous fluid under the skin between the periosteum and the scalp, and it often crosses the sutures, the suture line. But a cephalohematoma is a collection of blood, and it is confined to between sutures. It doesn't cross the sutures at all. It doesn't cross the suture line. It looks like this nice little pump knot on this baby's head, and it's a collection of blood between the periosteum and the scalp. And if you have a baby with the cephalohematoma, then that baby, as that starts to heal, and it can take weeks to months to heal, depending on how bad it is, but it can actually cause their bilirubin levels to be higher with the breaking down of that blood under the scalp as it's healing. This is the newborn assessment summary. I'm not going to go over it with you. It's on page 570. It's table 18.3. It is actually a very nice table for you to look at. I highly suggest you look at it and understand the usual findings versus the variations and common problems. Then YouTube has some pretty great newborn reflexes video, as well as your Canvas, the things that we include in Canvas for you. Newborn care, teaching about bathing. So we want to make sure that they gather all the supplies needed and put them within reach, work at a comfortable working height on a flat surface in a warmed area. Never leave the newborn alone or unattended at any time during the bath. And always support the newborn's head and neck when moving or positioning the baby. Place a blanket or towel underneath the newborn for warmth and comfort. And dry the baby as the different parts as you go down with a dry towel. And then cover that area up with a blanket to maintain their heat. You're going to sponge bathe the baby until the umbilical cord completely dries up and completely falls off the abdomen. Remember, you're going to progress from the cleanest to the dirtiest areas. So you'll start with the face, go down the neck, down the rest of the body, leave the diaper on and attack that area last. Get all the way down the body to the little tootsie toes, get the baby dried off, wrapped up, and then do the hair. and then do the diaper area last. Okay. Make sure you rinse all the soap off the baby and dry the area. At this time, it's a great time to observe for any rashes or anything like that on the skin in the diaper area. And just remember, please never leave a baby unattended. Diagnostic and laboratory testing. Newborn hearing screen is done usually anytime after 12 hours of age. So it's either ABR, auditory brain response, or OAE, which is otoacoustic emission system. And it's done by someone who is trained to do it. All it is a hearing screen. It does not predict future hearing loss, and any refers for the right or the left ear or both will require follow-up at a special visit with a specialist. As far as blood test goes, the newborn screening is a blood test done after 24 hours of age, but before discharge to home. It's a genetic screening and it tests for inborn errors of metabolism. So it tests for disorders like PKU, galactosemia, thyroid disease, cystic fibrosis, and it is mandated to be done in the state of Tennessee. It's not an option. Congenital heart screening is the oxygen saturation that's completed after 24 hours of age. Your book will tell you that 95% or above is normal. Then, of course, getting a bilirubin level. Transcutaneous is a skin level where it's a non-invasive way where it's done with a little machine that kind of reminds you of one of our touch-free thermometers. And of course, we also can get a blood sample, which is more invasive and requires a heel stick for a capillary sample or an actual venous stick. Umbilical cord care. We used to teach clients to use alcohol on the cord, but we don't teach that anymore. We are just teaching them to keep their cord clean and dry. Make sure the cord stays outside. The cord stump stays outside of the diaper. Don't tuck it in the diaper. Don't pull and tug at it. And the signs and symptoms of infection to monitor for, like extreme redness around the skin at the site, any green, smelly discharge, any active bleeding, things like that. Male circumcision, uncircumcision care is on page 572 and 573. Feeding while breast is best. Sometimes breastfeeding may not be possible, so you can do, the parents can do a donor milk, breast milk, or actually do formula. Box 18.2 in your book gives the advantages of breastfeeding. Table 18.7 is an example of the latch scoring tool that nurses use and lactation uses. And the teaching guidelines 18.4 teaches a lot about breastfeeding. So you have a big section on feeding. Table 18.6 compares breast milk with selected formulas. And of course, there's teaching guidelines for formula feeding and bottle feeding. Safety-wise, we need to make sure that we teach our clients not to prop bottles. Don't heat breast milk or formula in the microwave because it creates uneven hot areas in the liquid and can scald the baby. And then, of course, breast milk pumping and storage guidelines need to be reviewed as well. Lactation specialist referrals also need to be considered, no matter how or what a client chooses to feed. As far as infant safety, there's teaching guidelines 18.3. Discharge teaching started, it's specific to the patient and family needs and starts at birth. Okay, we start it from the get-go while focusing on safety and prevention as key. Follow-up teaching, we talk about the warning signs, which is a great thing for you to go over. It's in your book as well, page 589 through 590. It's also good to kind of go back and review that newborn assessment for your test out because it has those warning signs on there too. So that is the end of our newborn chapters 17 and 18, newborn care and management. So thank you for hanging out with me. I hope that I didn't bore you too much. It was two chapters that I reviewed with this, so hopefully you took you some good breaks and paused it and made some notes. I appreciate you hanging out with me. Thank you.